Assalamualaikum.
Waalaikumsalam.
Okay, right. Yeah, we test the voice. Everyone okay?
Yeah. Hello?
Yes, doctor, we can hear you.
Right. Has everyone joined?
Yes, doctor.
Okay, all right. I think why don't we start?
Can you see my slide?
Yes.
Yes.
Nampak.
Okay. So I will be the first presenter for today's long case. So, Haziq, 13 years old Malay boy, was referred from Hospital Ramping to HTAA with chief complaint of facial puffiness associated with lower limb swelling for 1 day duration. He was apparently well until 1 week prior to admission when he had a sudden onset of fever. It was continuous in nature and not associated with chills and rigor. However, no any documented temperature at home. He did not take any medication, but his mother did apply static sponging. However, the fever was not resolved. Throughout the fever, he appeared lethargy, not active like usual, and spent most of his time to lie down. Otherwise, there was no episode of loss of appetite or reduced in oral intake. Okay. So, he also claimed of having tea-colored urine 3 days prior to admission. The color was described to persist throughout the urination and was spotty in nature. He denied any presence of fresh blood or clots in the urine. The tea-colored urine was associated with reduced in urine output. Usually, he urinates about 5 to 6 times per day, but it was reduced to 1 to 2 times per day only. Otherwise, there was no other lower urinary tract symptoms such as urgency, increased frequency, or hesitancy, no abnormal swelling noted from the urine, and no lung pain during the menstruation. On the same day, he also had a sudden onset of headache for 3 days duration. He described the headache as throbbing in nature, felt at the occipital region, and occurred persistently throughout the day. There was no aggravating or relieving factor. The pain was moderate in severity, in which he scored the pain as 5/10 and does not affect his sleep. The headache was associated with blurry of vision and vomiting. It was a non-projectile vomiting, and he had vomited about 2 to 3 times, and the amount was about half cup per episode. The vomiters contained food particles with no blood or bile stain in the vomiters. Otherwise, he denied having any diplopia, neck stiffness, or altered behavior. On the day of admission, his mother noticed that he had facial puffiness and swelling around the eyes upon waking up from the sleep. It was sudden in onset and not associated with any underlying skin changes and also painless. The swelling was claimed to be most prominent in the morning, but gradually resolved towards the evening. There was no history of recent insect bite or any known allergy towards the drugs or foods. It was also associated with bilateral lower limb swelling up to the mid-shin level. It was heating and painless in nature. The lower limb swelling started in the distal extremity and progressed proximally. Despite the swelling, he was still able to ambulate and continue his daily routine. Otherwise, it was not associated with lower limb heaviness or squatting swelling. There was also no shortness of breath. The patient did not notice any abdominal distension, and he denied any marked increase in the weight. On further questioning, he had history of impetigo. He had history of skin infection 3 weeks prior to the onset of fever that affect both of his upper limb and lower limb. He went to general practitioner to seek medical treatment and was given topical medication and also antibiotics. However, patient claimed that he was not complying to the medications given. Otherwise, he had no history of URTI such as cough, runny nose, and sore throat. There was no rashes, alopecia, arthritis, or loss of weight. He denied any underlying cardiovascular disease and no further symptoms such as chest pain, orthopnea, TMD, or reduced effort tolerance. There was no abdominal pain, yellowish discoloration of sclera, and he had no previous history of CLD. This is the first episode with similar and no history of similar symptoms before. He had no family history of renal disease or autoimmune disease. Due to the facial puffiness and lower limb swelling, her mother brought him to hospital Rompin, and in hospital Rompin, urine test was done and it was revealed that he had blood and protein in the urine. The blood pressure was also taken and he was also told to be hypertensive. Medication was given and he was referred to HTAA for further management. Unfortunately, along the way to HTAA, he had 3 episodes of seizure in the ambulance. During the attack, the mother who witnessed this episode described the seizure as sudden jerking of both upper and lower limbs with upwelling of the eyes and also drooling of the saliva. The episode lasted about 2 minutes and aborted spontaneously. There was no twitching of the face, tongue biting, bowel or urine incontinence, color changes, or any bleeding abnormalities. However, about 10 minutes later, he had developed another 2 episodes of seizure with the same characters and also duration. He was given medication to abort the seizure. At the evening of HTAA, again the blood pressure was taken and showed high reading. CT brain was done and the mother thought there was no abnormal finding in the CT brain and he was transferred to the PICU and admitted for close observation. Systemic review revealed no significant findings. For the past medical and physical history, this is his second hospitalization. He had been admitted at the age of 2 years old due to pneumonia. Otherwise, he had no non-medical illness. For the birth history, antenatally, the pregnancy was uneventful. He was born full term via spontaneous birth delivery, and his birth weight was 3 kilograms, and his postnatal history was also uneventful. He was on exclusive breastfeeding up to 6 months before mixed with formula feeding. He started on weaning at 6 months old with soft food. Currently, he is on adult diet, which contains rice, chicken, beef, and also eggs. For the immunization history, he fulfilled his immunization schedule. He just finished his UPSR and passed all the subjects. He is active in sports, in which he loves to play football, and he was also active in other co-curricular activities at school. He was able to make friends and has a lot of friends. For the family history, he is the 3rd child out of 5 siblings. His younger sister had bronchial asthma, while other siblings are healthy. His father, 50 years old, also had bronchial asthma and hypertension, while his mother, 36 years old, had no non-medical illness. There was no history of renal disease or autoimmune disease in the family. He lived with his family at Tanah Putih, Romping, in a single-story house with adequate basic amenities. His father, who is a non-smoker, worked as a cleaner at Hospital Romping, while her mother worked as promoter with household income of 3,000. So that's all for the history. For the physical examination, it was done on 16th day of admission. On general examination, the patient was lying comfortably on the bed in supine position. He was conscious and alert and also comfortable. There was no branula attached to the dorsal. There was a branula attached to the dorsal part of left hand without any inclusion. There was no on the peripheral examination. There was no stigmata of chronic liver disease such as pulmonary edema, clubbing of left ventricle, and also no stigmata of infective endocarditis such as generalization or splenic or splinter hemorrhage. There was also no pale jaundice or rash in the mouth. It was noted to have good oral hygiene with good hydration status. The pharynx are not injected, and there was no bipedal edema. Further
Any chance that you had the serial measurement of the blood pressure on charted or on a chart?
no, doctor.
Okay. So okay, all right. I mean, don't expect anything on physical examination. So based on the history admission, right?
Hmm.
What would be the differential diagnosis initially
My
based on?
professional diagnosis will be post-streptococcal glomerulonephritis,
Okay.
and
Other
my
differential?
differential is glomerulonephritis caused by other causes such as IgA nephropathy, and also other differential is urinary tract infection, HSP, and also meningoencephalitis.
All right. Okay. Edema. Okay. All right. Okay. Continue.
For the vital signs, the vital signs were normal except that the blood pressure was slightly high, which is 121/73 millimeter mercury. So in 13 years old boy, so it is considered as pre-hypertension. Okay. On abdominal examination, on inspection, the abdomen moved symmetrically with respiration, and the abdomen was not distended. There was no scar or abnormality noted, and the umbilicus was centrally located and inverted. On palpation, it was soft and non-tender. There was no hepatosplenomegaly, and the kidney was not dilatable. But shifting dullness and renal punch were negative. On auscultation, bowel sound was heard with no renal buoy. On neurological examination, the Glasgow Coma scale was full, and there was no abnormalities detected in the motor, sensation, gait, and also cranial nerve examination. Other systems were unremarkable.
Okay. All right.
Okay, for the summary, Haziq, 15 years old Malay boy with history of impetigo 3 weeks prior to admission, was presented with fever and lethargy for 1 week, oliguria, hematuria, and symptoms of hypertension for 3 days duration. Then he developed facial puffiness, periorbital edema, and also bilateral lower limb swelling 1 day prior to admission, with 3 episodes of generalized tonic-clonic seizure on the day of admission. Otherwise, he did not other lower urinary tract symptoms, skin rash, joint pain, or abdominal pain. On physical examination, it was revealed that he had pre-hypertension with no other abnormal findings. So my professional diagnosis will be post-streptococcal acute glomerulonephritis complicated with hypertensive encephalopathy. This is because he had history of impetigo, and he developed facial puffiness, periorbital edema, bilateral lower limb swelling, oliguria, hematuria, and also showed the complication of PSGN, which are high blood pressure, complicated with generalized tonic-clonic seizure. I could not find any points again for this my provisional.
Okay.
My differential analysis will be IgA nephropathy, which is other causes for glomerular nephritis because he presented with facial puffiness and also lower limb swelling, hematuria, proteinuria, and also hypertension, and he had history of bacterial infection. However, usually in IgA nephropathy, the the disease is preceded by they will usually it was commonly associated with the upper respiratory tract infection compared to skin infection, and there was no family history of renal disease in terms of blood-based disease in IgA nephropathy. Other DDF is urinary tract infection because he had hematuria, fever and lethargy and also vomiting. However, it is uncommon in male and he had no other lower urinary tract symptoms. For the HSP, it was because he had bilateral lower limb swelling, hematuria and proteinuria and also hypertension. But there was no upper urinary tract infection and also no rash, arthritis or abdominal pain. And my last differential will be meningoencephalitis because he had fever, headache, blurred vision, and also seizure, and also vomiting. But the vomiting is non-projectile, and there was no neck stiffness or change in behavior. Should I proceed to investigation, doctor?
Okay, continue. Yeah.
Okay. So investigation, I would like to divide into blood investigation, urine, and also imaging.
Okay, highlight the abnormality. Just highlight the abnormality. What to your friends? What is
For
abnormal?
the blood, for the full blood count, there is mild anemia and also leukocytosis with predominance of neutrophil. For the renal profile, there is presence of high urea and creatinine, which indicate ongoing kidney injury, acute kidney injury. For the liver function test, there is hypoalbuminemia with high globulin level. Blood TNF is normal. For the complement level, it is classical for PSGN because he had reduced C3 level with baseline of C4 level. And the SOT is also high. For the urine, there is presence of leukocyte with proteinuria and also hematuria. For the imaging, chest X-ray is normal, and CT brain, it was done twice for this patient, and the first CT brain showed changes of cerebral edema, and the second CT brain showed features of stress with no complication such as infarction or ICD. So the final diagnosis for my patient is post-streptococcus acute glomerular nephritis complicated with acute kidney injury and also hypertensive encephalopathy with posterior reversible encephalopathy syndrome. Is it correct, doctor?
Okay, all right.
Okay. So we go to the management. So because this patient had hypertensive encephalopathy, so what is hypertensive encephalopathy? It is characterized by severe BP elevation with cerebral edema and also neurological symptoms. So, however, it can also with no extreme BP elevation when the hypertension appears to as a sudden onset, such as in this patient. Okay, so we need for the investigation we need to do CT brain also MRI. So with regards to posterior encephalopathy syndrome, so I covered a little bit because we never heard it before, right? So what is posterior encephalopathy syndrome? It is a neurotoxic state that occurs secondary to inability of the posterior circulation to auto-regulate in response to the acute changes in the blood pressure. So basically, it is because of the high BP, so loss of self-regulation, causing hyperperfusion, which leads to endothelial damage and also vasogenic edema. So the clinical presentation is headache, seizures, encephalopathy, and also visual disturbance. These symptoms are all present in my patient. And for the radiographic features, we can find vasogenic edema in the occipital and also parietal regions. 95% occur in this region. However, it can also be in other area, which is watershed area in other frontal part. Okay. So the complication for first is parenchymal infarction, also hemorrhage. So this I just want to show you okay, the vasogenic edema. You can see at the occipital region. Okay. So for the management for hypertensive encephalopathy, because it is medical emergency, so we need to admit the patient into ICU or HDW, and we have to immediately do vascular access, meaning that we have to put granular, and then we need to monitor the neurological status, cardiac and continuous BP, and also urine output, and we manage any complication, and we need to lower the blood pressure gradually to avoid intracranial bleeding. And our goal is to reduce the MAP by 25% over the first 24 hours. So in emergency, hypertensive emergency, we need to give IV drugs instead of oral drugs, such as IV labetalol. Okay. For the management of PSGN, as the patient becomes stable, first we need to secure the airway, breathing, and circulation, and then we need to monitor. The nephrotic chart, which include fluid intake, urine output, daily weight, and also BP. And because this patient also had had fever and seizures, so we need to monitor for the temperature and also seizure chart. For the medication, to eliminate the GABHS infection, we give penicillin B for 10 days. And if the patient persistently had high BP, we need to give antihypertensive. And then to reduce the edema, we can give fluid injection, also diuretics such as IV furosemide. And also for the diet, we need to advise the patient to avoid to take no added salt, and also no need for protein restriction. And we need to monitor for any complication of PSGN. Okay, I think that's all from my presentation, Doctor.
Okay, all right. Any question from the rest? It's actually very common. I mean, you can have this in long case, especially if a patient. Why? Any idea why this patient has to stay very long? Huh?
Because of hypertensive encephalopathy.
No, usually by 72 hours, the BP will be reduced already.
Oh, because the BP was not stable. It's still high.
Okay, yes, persistent hypertension.
Persistent,
All right, okay.
mm.
Actually, what do you think the mainstay of? What is actually the mainstay of treatment for? What is the best antihypertensive for this patient actually?
Certain, Doctor?
What is the best antihypertensive for this patient actually?
IV labetalol in acute emergency.
Yes, but for emergency, but for subsequently for maintenance, what is the best?
Nifedipine.
Should be furosemide. Why? Why furosemide? Why?
To avoid, to reduce the hydrostatic pressure.
Why? What is the
Because
pathophysiology of hypertension in glomerulonephritis?
for the pathophysiology,
Yeah,
Because
of
there is
the
sodium and water retention.
okay.
due
So
to
sodium and
the
water
water
retention
activation.
causing
Causing edema.
So edema cause what?
Edema cause high
It's
blood
not really
pressure.
edema. Actually, salt and water retention causes what leads to the hypertension. Yes, salt and water retention, but salt and water retention alone will not cause hypertension. What happened after that?
Increase in hydrostatic pressure. So shift
Hydrostatic
fluid.
pressure, not really.
Mhm.
Because this patient albumin in AGN is different from nephrotic syndrome, you know.
Nephrotic.
If you understand the pathophysiology, then you understand that the basic of treatment is actually furosemide the best. That's why if you use nifedipine anti-hypertensive alone, it will not improve the condition. So salt water retention, then causing what? Hypovolemia, volume expansion. Volume expansion is the one actually causing hypertension. Okay. What causes the salt and water retention then?
RAS activation.
Yes, RAS activation. Okay. So this is a question that you'll be asked in your long case. So this one's very common in long case. All right. Okay. Probably in this situation, you probably have to use combination of antihypertensive, correct? All right. Okay. All right. Understood. Okay. No question from the rest. Then we proceed with the second presentation.
Can everyone see the slide?
Not yet.
Not yet.
Yeah, okay. Wait, If I am lagging, I hope you guys can tell me because the internet connection is not quite good. Okay. Now can you, okay, oh. Okay. I'm sorry, wait a minute. I'm sorry, suddenly they have there's some problem with my laptop. I'm trying to open the slide back.
Why did you want Alice projecting a slide?
Yeah, it got crashed. Wait,
You can
I'm trying
send the
to see.
file to us.
Alright,
We can share the slide to you.
okay.
You
Okay.
try to can you try to log out and join again?
Okay.
Uh,
May I know? Okay. Can you guys? Okay. Can everyone see the slide now?
yes.
Okay. Alright. Can Daya open in the slideshow?
I already opened in slideshow. No. Okay.
It's not in slideshow yet.
Now?
Yeah.
Now it's not in slideshow.
Yes.
In slideshow.
No, no. Not in slideshow.
I think it's okay. Kalau tak ada pun you continue. I think we can see.
Okay.
Okay.
Alright. Daya, can you go to the first slide? At the chief complaint first.
Can you see it now?
First slide. This is the second slide.
In my screen already first slide je eh. Kenapa dia?
Do you want me to share the slide?
Tak ada betul.
Anyone else has his her slide? If someone else got her slide,
Yes.
I think probably use your slide and then what's your name? Sorry, you just use your slide and say next slide if you want to move. All right. This is
Yeah.
yours, right? We try. Okay, we try. See. Okay.
Okay. Okay. My name is Nadira. I am sorry for the delay. So I'm gonna start the second presentation. So for the second case, my patient FZ, a 6-year-old Malay boy, non-medical illness, presented to emergency department of HTAA with complaint of cough and shortness of breath for 1 day duration. Can you go next? Okay. So for the history of presenting illness, he was previously well until 4 days prior to admission, where he started to develop intermittent cough. So the cough was described as non-productive, barking in nature, worse during the night, and there are also some association with hoarseness of voice. So at that point of time, the cough was still bearable, which rendered the parents not to seek out any medical attention or give any medication to the patient. However, a day prior to the admission, the cough became worsened and increased in frequency, and suddenly it was associated with sudden onset of noisy breathing. The noisy breathing was described as whistling sound, which prominently heard during inspiration. Later, the patient had also complained of difficulty in breathing and become more lethargy. The parents otherwise did not notice any bluish discoloration of the skin, any usage of accessory muscle, confusion or loss of consciousness in their child. He had a history of sick contact where his mother had a running nose and cough around the same time the patient start to have his symptoms. Otherwise, the patient himself did not have any other coryzal symptoms or fever, no known allergy to any food or medication, no abnormal sitting posture. There is also no sudden facial puffiness, body swelling or rashes, and there also no history of ingestion of foreign body. His parents also deny any history of traveling, and there is no drawing of saliva or decrease in meal intake noted in this patient. Next. Following the sudden onset of difficulty in breathing, he was rushed immediately to the emergency department of HTAA. Blood and X-ray of the chest was taken, and he was given nebulization and intramuscular medication. He had one episode of hypostatic vomiting at ED, which was a non-projectile, amounted to a quarter cup of food particles, non-bilious, and next one. So moving on to the past medical history, this is his second hospitalization. He had first hospitalization when he was 8 months old, where at that time he experienced sudden continuous cough that until he appeared blue. Before his parents rushed him to Hospital Jengke. They suspected he had ingested foreign body, but X-ray failed to prove that, and parents did not know the real diagnosis of the patient condition. He was admitted for 4 days, at that time, and discharged with no follow-up or any medication. Otherwise, patient did not have any other medical condition nor had undergone any surgery before. For his birth history, and he was born at terms via spontaneous vertex delivery with birth weight of 4 kilogram and was uneventful. Antenatally, his mother did not have any gestational diabetes, pregnancy-induced hypertension, or having any infection while pregnant with him. However, postnatally, he did develop neonatal jaundice that lasted for 3 days, but no intervention was done except for close monitoring at the nearby clinic. Okay, proceed to the nutritional history. He was exclusively breastfeed since birth until the age of 1 year old, where mother stopped breastfeed him in view of delivering his younger sister. He refused to drink formula milk and stopped taking milk until just recently. He will take Dash Lady milk 2 times per day. He started to wean at the age of 6 months old and by taking rice porridge, and currently he is taking balanced adult diet 3 times per day. He had completed his immunization based on the national guideline, and his developmental milestones were up to age. For the family history, his father is a 50-year-old with underlying diabetes mellitus on oral hypoglycemic agent. The mother, also 50 years old, has no other comorbid. He has 7 siblings, consisted of 2 boys and 5 girls, with the oldest age 24 years old and the youngest is 5 years old. Otherwise, there was no medical illness that runs in the family and no other sick contact other than previously mentioned before. For the social history, his father is a driver lorry and an active smoker who smoked 30 pack per year but do not smoke in the house or near his children. The mother is a full-time housewife. All family members were currently living together in a terrace house with 3 rooms and admit to have adequate supply of water and electricity at Batu 12. The household income total at 5,000 ringgit, including money given from the older sister. Next one. Okay, that's all for the history regarding the presentation. So moving on to the physical examination. The examination was done on the second day of admission. He was conscious and alert. He was sitting comfortably on his bed, not in respiratory distress or in pain. He had occasional barking cough. Otherwise, there is no stridor heard and no sign of cyanosis being seen. He had no pallor. His hydration status was good. There were also no dysmorphic features. His capillary refill time was less than 2 seconds. All his vital signs were within the normal range. His weight and height were plotted on growth chart and both parameters were between 25 centile to 15 centile. Next one. Okay, as mentioned before regarding the anthropometric measurement, it was within the normal standard deviation, and for the vital sign, he was normotensive at the time of examination. The pulse rate was normal, 60 beats per minute with good volume and regular rhythm. He is not tachypneic and he is febrile at that point of time, and SpO2 was 99% under room air. So moving on to the specific examination, which is respiratory examination. On inspection, the chest moved symmetrically with respiration. No sign of respiratory distress or deformity seen. On palpation, the chest expansion was normal, tactile parameters was normal, and the trachea was centrally located. On percussion, it was resonant all over the chest. On auscultation, air entry was good with vesicular breath sound and no added sound. Examination of other system appeared to be normal. Okay. So on the summary of my case, my patient, FZ, a 6-year-old Malay boy with no non-medical illness, presented to emergency department of HTAA with complaint of worsening cough and shortness of breath for 1 day duration. He started with intermittent barking cough and hoarseness of voice for 4 days prior to presentation, which become worsening and associated with stridor and difficulty in breathing. However, in physical examination on the second day, it showed unremarkable finding except for the presence of barking cough. Okay, so this would be my provisional diagnosis and differential diagnosis. First, the provisional would be a viral croup due to the hoarseness of voice, stridor, barking cough, and the causes of barking cough commonly would be viral croup. And the point against this diagnosis would be the age of the patient itself, since the viral croup would be found within less than 3 years old, and patient also experienced no fever. The first differential would be bacterial tracheitis, which because the age of the patient itself and hoarseness of voice, stridor, and barking cough against no high-grade fever. Next one would be acute epiglottitis. But the points again, no high-grade fever, no tryptocyte, no drooling of saliva, no complaint of difficulty in swallowing. And then there also my differential would be foreign body inhalation. Can you move at the next slide? Yes, foreign body aspiration. So the points for this diagnosis would be hoarseness of voice, stridor, barking cough, and worsening cough. The points again is that there is um, there is a history of sick contact and the symptom was not sudden. Okay. Actually, the angioedema is not my differential, but I did not manage to edit it because it suddenly crashed. So that's all. Should I move into investigation,
Yep,
doctor?
okay.
Okay, for the investigation in this patient, first we do the full blood count to look for any leukocytosis as a sign of infection. But the impression on this patient, it is normal. All parameter was normal. So renal profile to look for any electrolyte imbalance, since patient did vomit once and look lethargy on the presentation. However, the parameter also normal. C-reactive protein to look for any evidence of ongoing inflammation. But in this patient, it was not done. Okay, next one. Okay, next for the since my provisional diagnosis would be viral group, so I would like to suggest influenza rapid test to rule out influenza virus for to rule out influenza virus. However, it's not done in this patient. And for the sputum culture, to look for any organism for membranous group or other bacterial causes that can cause group, but no organism were found based on the result in this patient. So next one for the radiological investigation, chest X-ray to rule out any foreign body and lower respiratory infection, and any evidence of epiglottitis such as thumb sign or any steeple sign. But in this patient, the result are normal. Okay, that's all.
Okay.
So
Yeah. Online, your management plan for this patient.
okay, so for my management regarding this patient, first if I saw this patient for the first time, since patient come with difficulty of breathing, I would like to secure the airway, breathing and circulation, make sure there is no obstructed on the airway, and once that's and then I assess the GCS of this patient, and then I take the vital sign of this patient. If patient was febrile at that time, I would like to give antibiotic to this patient, and based on the history and physical examination, I would like to classify patient under mild severity of group of viral group. So the medication that I would like to give would be dexamethasone. And then I would like to monitor patient for hourly, and if patient improve, we could discharge patient, because mild, if I'm not mistaken, mild severity of viral group doesn't need admission, doctor, or still need admission?
We this I mean we didn't, it's difficult because we are not there in emergency department. So probably the other criteria that why this child was admitted, right? So usually if they have a concurrent, they suspect the patient may develop respiratory distress, probably that's the indication for admission. Okay, and usually if the child who needs the dexamethasone is already considered as not mild. If mild child probably resolve with just nebulized corticosteroid. Once you give dexamethasone inside the child, is already under category of either moderate or severe. So it's difficult because those who are in emergency department probably can give you a view. But most likely this child has moderate to severe group and in emergency department. Okay, actually, I'm not sure. This patient was taken before COVID, right? The case.
Yes.
So that's why I think most likely that time was if this happened before March, then that is a time where influenza outbreak or epidemic occurs. So that's why this patient probably was started on Tamiflu. But what is the commonest cause of viral flu? Is it influenza?
Para-influenza
It's
virus.
different. So para-influenza and influenza is totally different. So you send, unfortunately, in government hospital, you can't do the PCR test because you can, but on this specific case, but this is quite expensive. If you do viral PCR, then probably you have many panels including para-influenza. So that's the best. If you only do influenza, it may be positive, it may be negative, right? But generally, but I mean, if you work in this hospital, understand it's actually quite pricey. But you have to understand there's a viral study. You can do viral PCR. Viral PCR. Influenza is just one of them. Any question? Okay, quite this one. This is also if this patient in ward during exam, then probably it will be both a long and short case. Long and short case. So nothing much. I mean, most importantly, you should come up with differential analysis just now. Croup, acute hepatitis, bacterial tracheitis are things that you must differentiate. At least give these three differential. Okay, any question? Okay, I mean, quite very good. No, I'm no comment. Any question?
I have question.
Yeah.
Regarding the management. Sorry, Doctor.
Yeah. Please proceed. Yeah.
Regarding the management of viral group, is there any guide to tell us that we should offer the DEXA first or the NAP, budesonide first?
Actually, evidence say that both are equally effective, right? Whether you give you can give a try. Of course, we will try to give a nebulizer first because that is the least invasive. Another option is actually oral prednisolone, but problem is most children prednisolone is very bitter. Most of them will refuse prednisolone, right? So in most instances, after giving the nebulized corticosteroid, majority of patients they will show 50% improvement, right? So usually, but this patient say they receive two. but did not improve. Okay, that's why they give the dexamethasone. That's why I feel the category in this patient by that at the time we didn't manage the patient. But I think most likely child already has a moderate to severe lah. Otherwise, they will not give the dexamethasone. So, but in the mild situation, either three evidence base is the same, right? So either you give nebulized corticosteroid, oral prednisolone, or dexamethasone, IV or IM is actually equally effective. So that would be, I mean, of course, the more acceptable is nebulizer than rather than injection, but that would be depend on the situation. Okay.
Thank you.
Remember, if you suspect epiglottitis, don't examine the throat. Okay, they may just have a spasm, and after that, you're probably not able to intubate them because the airway obstruction. So you want to check the airway patient with epiglottitis and bacterial tracheitis, you must do in OT and the ENT. Because if they can't pass the ETT, they will do a emergency tracheostomy. Okay. Any other question? Okay, all right. If no question, then okay, we end the session. All right. Okay. Assalamualaikum.
Waalaikumsalam. Thank you very much.
Waalaikumsalam.
Thank you,
Thank you,
Doctor.
Doctor.